Paroxysmal nocturnal dyspnea is a cardinal symptom of left ventricular decompensation. While often grouped with orthopnea, its underlying biophysical triggers and delayed onset during sleep make it a distinct and highly specific clinical marker for elevated left-sided filling pressures. The onset of PND is driven by a complex interplay of postural fluid shifts, ventricular mismatch, and sleep physiology, typically occurring 2 to 4 hours after falling asleep. The preload surge, fluid redistribution. When a patient transitions from an upright to a supine position, gravity ceases to pull blood in the lower extremities and splanchnic bed. The gradual mobilization of dependent interstitial edema increases central venous return. The right ventricle pumps this augmented volume into the pulmonary circulation. The left ventricular mismatch. In the setting of left ventricular systolic dysfunction or reduced compliance as in heart failure with preserved ejection fraction, the left ventricle cannot accommodate the increased pulmonary venous return. This creates an acute hemodynamic bottleneck. The left ventricular end diastolic pressure and left atrial pressure rise significantly, directly transmitting retrograde hydrostatic pressure to the pulmonary capillaries. Stalling forces and transudation. The accumulation of fluid in the pulmonary interstitium is governed by the Starling's law of capillaries. This has been detailed in the recent video on pulmonary edema. Where capillary hydrostatic pressure Pz drastically exceeds plasma oncotic pressure pi c, the resulting fluid transudation thickens the alveolar capillary membrane, decreasing pulmonary compliance and impairing gas exchange, causing hypoxemia. The sleep physiology component. Unlike orthopnea, which occurs within minutes of lying down, PND is delayed. During sleep, central respiratory drive is depressed and sympathetic nervous system tone decreases. The blunted adrenergic response prevents the heart from increasing contractility to handle the preload surge. The reduced sensitivity of the respiratory center to mild hypoxemia allows pulmonary congestion to silently accumulate until a critical threshold is reached. The patient is then abruptly awakened by severe air hunger, tachypnea, and sympathetic surge. Identifying true PND is critical for differential diagnosis and risk stratification in cardiology and internal medicine. While dyspnea is a broad symptom, PND is highly specific for congestive heart failure. Here is a comparison. PND timing of onset 2 to 4 hours after sleep. Relief mechanism sitting upright for 15 to 30 minutes. Hallmark feature abrupt awakening, severe air hunger, coughing. Orthopnea, on the other hand, occurs within 5 minutes of lying down flat, and sitting upright immediately relieves symptoms. Predictable positional intolerance is there. Obstructive sleep apnea occurs intermittently throughout sleep with brief arousal which relieves symptoms, and CPAP, continuous positive airway pressure, is an important therapeutic relief. Hallmark features snoring, witnessed apneas, daytime somnolence, which is due to poor night sleep. Asthma, nocturnal asthma. Early morning, that is the circadian dip. Relief is with bronchodilators. Hallmark feature wheezing, chest tightness, unrelated to posture. The cardiac asthma mimic. Because the interstitial edema of PND can compress small bronchioles, patients may present with wheezing rather than classic crackles. This quote-unquote cardiac asthma is frequently misdiagnosed as an exacerbation of COPD or late-onset asthma, leading to inappropriate treatment with beta agonists, which in fact may provoke arrhythmias, rather than the required loop diuretics.